Welcome everyone to this online section on ophthalmology. I am Dr. Huang from the JSIEC. Today we will discuss about bacterial keratitis. I hope that through this section you will recognize the anatomy, pathology, clinical features, diagnosis, as well as the management of bacterial keratitis. Before class, I would like to show you a case. A young man came to our emergency department with severe visual loss and a painful red left eye for 1 day. He used a contact lens every day. The eye was stained with sodium fluorescein. So, what might be the probable diagnosis and how to deal with it? I hope that after this section, you can have good answers to all the questions. We may need to go over something about the normal cornea. The cornea serves as a lens to our biocamera, which is transparent, contains no vessels but very dense nerve fibers, so that it is the most sensitive tissues in the body. The cornea contains 6 layers, and each layer plays its role on the structure and transparency of the cornea. We know that the epithelium and the distal membrane are renewable, while other layers are not. Any damage to the cornea may lead to pain, opacity, edema, neovascularization, and corneal decompensation. Now let's move to keratitis, which is one of the major causes of blindness and impaired vision in developing countries. Keratitis is an inflammatory condition of the cornea tissue involving one or more of its layers. It can be caused by infections, trauma, chemical burns, corneal dystrophy, autoimmune disorders, and so on. Infectious keratitis can be further classified as a bacterial, a fungal, a viral, and parasitic. We will concentrate on bacterial keratitis today and fungal and viral keratitis in the following sections. Bacterial keratitis is a serious vision-threatening infectious eye disease with rapid onset, speedy development with severe eye irritation symptoms. Predisposing factors may include extended use of contact lens, a corneal trauma, contaminated water or eye drop, and compromised immune states like drug abuse, HIV, or diabetic mellitus. The infection causes mixed conjunctival injection, hypopyon, corneal edema, and anterior uveitis. This slide can help us to get a better understanding of the occurrence and development of bacterial keratitis. The bacterial induce an ulceration through direct invasion and cell-mediated immune response. The ulceration, if not treated, may further lead to either perforation or a dysmetocele, based on the bacterial virulence. In some cases, the infections may progress to endophthalmitis, which is one of the most dangerous conditions. The prognosis varies from a slight scar to a staphyloma, which is often associated with secondary glaucoma. In clinical practice, we can make a preliminary diagnosis of bacterial keratitis based on the history and the typical exam findings. For a definitive diagnosis, scraping of the corneal tissue, cell culture, and PCR are needed. In the meantime, empirical antibiotic treatment should be started. Management of bacterial keratitis include antibiotics, anti-inflammatory agents, and surgery, of which antibiotics is the most common. Polymyxin B, gentamicin, and fluoroquinolone have been proved to be effective in most cases. Early and combination therapy are preferred when the specific pathogen has not yet been identified. Here are the common pathogenic bacteria leading to bacterial keratitis: the Staphylococcus epidermidis, the Streptococcus pneumonia, and the Pseudomonas aeruginosa. We need to adjust medications regimen according to the specific pathogen identified. Here we have a list of antibiotics with recommended concentration used. Each antibiotics are sensitive to different kinds of bacteria and should be selected correctly in clinic. Empirical treatment necessary usually with fluoroquinolone and sulfasalazine and with or without gentamicin. In case of refractory infections or corneal perforation, a corneal transplantation is the only treatment and should be performed. A conjunctival flap can be considered if a corneal donor is unavailable. To summarize, bacterial keratitis often begins with acute attack of severe eye irritation and decreased vision, then develop mixed injection, corneal ulceration, iridocyclosis, and sometimes perforation and endophthalmitis. Diagnosis depends on laboratory identification. However, prompt clinical diagnosis and management are very important. We should promptly start antibiotics combined with anti-inflammatory agents. A keratoplasty or conjunctival flap should be considered when perforation is present. Here are the references. I want to express my gratitude to Dr. Frida Law from Medical College of Shantou University and Dr. Lin Yi Liang from Zhongshan Ophthalmic Center for supporting this work. This is an online section of ophthalmology, and thank you very much for your attention.